Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
Periodontal surgical procedures are most of the time very difficult to accomplish when working alone, especially with varying amounts of hemorrhage, saliva, and with the various anatomical structures that restrict our visibility of the surgical site. This program is done to provide you with an opportunity to become familiar with some of the things that an assistant can do for you while treating a patient in periodontal surgery. Help by an assistant permits you to concentrate on the surgical procedure and to do a more thorough and complete service for the patient, and you may do this in a more comfortable and stress-free manner both for yourself and for the patient. You should be aware that the cubicle, the dental unit, and the chair have been cleaned, the instrument trays and necessary supplies are available, and the instruments are arranged in trays in the approximate order of their use. As instruments are used, they are returned to the original position on the tray so that they are readily available for reuse. The patient's record and radiographs are out, and the patient has been prepared for periodontal surgery with the hair covered, a large drape placed, and the lips and skin area about the mouth have been cleaned. You should also note that the operator and the assistant have prepared for surgery by scrubbing and by putting on a hat and rubber gloves. The procedures we would like to demonstrate have to do with the things the assistant will be helping you with during periodontal surgery. These will be basically things related to passing of instruments, to aspiration techniques and retraction techniques during the procedure. And we'll begin with administering the local anesthetic for our patient, and we'd like you to take special note of the passage of the syringe during the injection. Passing of the syringe is a bit different from passing of the regular hand instruments, and we will demonstrate passing of the syringe as we inject our patient at this time. You may close just a bit if you'd like, Mr. A.J. As you note in passing the syringe, the assistant is holding the barrel of the syringe with her fingers covering the plastic cover for the needle. She places the syringe over my thumb, and we're able then to make the transfer very nicely. You should have noted that the exchange of the syringe occurred to the left of the patient's chin, out of the patient's line of sight, and away from the face area. We will inject around the mandibular anterior teeth and wait a few moments for the anesthesia to become effective. Now, as we have our anesthesia, we'll begin the surgical procedure, but let me remind you that the purpose of this tape today is not to demonstrate the technique of a periodontal surgical procedure to you, but it is to do those things that the assistant can help us with, to demonstrate those things that the assistant can do for us during the periodontal surgical procedure. We'll begin at this time again with the initial incision and the passing of the scalpel handle and blade, which again is somewhat different from passage of the regular hand instruments, and we'll begin at this time with that demonstration. With the scalpel, we usually move slightly back away from the patient's chin area so that we're not in close contact with the patient's face, and we can move then directly into the mouth from that position. Aspiration, please. Initially, during the surgical procedure, you may notice that there is somewhat a profuse bleeding, depending upon the nature of the case and the nature of the procedure. But as the procedure continues, usually the hemorrhage problem is lessened and poses no problem with good aspiration. We continue making our incision around the neck of the 4 mandibular anterior teeth that we'll be dealing with today. We're making what's called an intrasulcular incision so that we can reflect the gingival tissues back and have access, therefore, to the underlying periodontal defects. And once again, as I complete the intrasulcular incision around the necks of these teeth and prepare for the passage of the scalpel and handle, exchanging for another instrument, we will move then just slightly away from the patient's mouth for the transfer to the number 7 instrument for retraction of the flap. You will note that our assistant moves continually back and forth over the area of surgery. Rather than staying in one place, she moves along the whole surgical site. She tries to anticipate where I'll move to, and this is of a great help in aspirating ahead of us so that the area that we need to visualize is clearly viewed. At the same time she's aspirating in the surgical site, she will also periodically move in the area underneath the tongue and in the posterior part of the mouth so that we can clean the accumulation of saliva and hemorrhage from that area of the mouth. The patient, many times having the accumulation of saliva in the posterior part of the mouth and the throat area, is somewhat bothered by the accumulation of this material, and periodic movement of the aspirator into those areas will help to relieve the discomfort or the uneasiness that the patient might feel with the accumulation of these products. She also can help by using fingers for retraction. There are times when we'll be using the instrument for retraction also, but constant movement of the aspirator throughout the area provides us the best access to the surgical site. Now, can you open wide for us, please? I'll need the scalpel again. Again, we move back slightly and transfer the scalpel and the mirror also. If you'll open wide for me, please. Making the incision around the cervical area of the teeth on the lingual aspect of the teeth so that we have some access to the lingual areas also. The periodontal problem primarily is involvement in the interproximal areas. We need to acquire the best access we can then into the interproximal areas. And again, periodic removal of the hemorrhage from the labial areas as well as darting in periodically on the lingual areas clears that area for me and does not obstruct my view in trying to make the incision around the lingual aspect of these mandibular anterior teeth. The number 7, please. Wide for me, Mr. A.G. There are times when we'll move from the 8 o'clock position of the chair, rolling around to the approximate 11 o'clock position of the chair. This affords me a better view of the area that we need to see. It also permits the assistant to view the area somewhat better in many cases. You will note that she uses the aspirator in a manner where the tissue is not continually sucked into the aspirator tip. Ideally, we'd like to use the aspirator in a manner that moves it along sideways in the area rather than in a straightforward or a punch-like manner, so that the tissue is picked up and sucked into the aspirator, where it, in the course of the procedure, certainly causes more trauma to the papilla and to the gingival areas. There are times, in spite of using as much care as you can in the surgical procedure, that the area around the mouth of the patient becomes somewhat smeared from the oozing and bleeding. The assistant at those times can move in with a saline sponge that she has close by on the tray, wiping the areas more cleanly so that we can see, and also cleaning the area around the patient's mouth so that we do not get an accumulation of dried blood and other products in those areas. Now the number 14 curette, please. In the passage of these instruments, we can stay primarily in the surgical site as the assistant moves in and just simply removes the instrument that I have completed the use of from one hand, and we transfer the instrument then directly to the other hand and back to the surgical area again. Let us demonstrate this once more, please. May I have the periodontal probe? And you note as she moves in with the probe, I hold the instrument directly in front of the patient's mouth, hardly removing it from the surgical site, as she comes in parallel to the instrument that I am about to give up, and we make the transfer then smoothly and are able to go right back to the surgical site to explore or use the instrument as necessary. Now the curette again, please. We many times will be able to use the mirror for retraction or the aspirator tip occasionally for retraction in cleaning around the surgical site. The end of the aspirator tip many times can be placed in the area that is helpful in reflecting the flap as we go around the necks of the teeth to curette in the area where the chronic granulation tissue has built up in the area of surgery. You note that as we displace the diseased tissue from the interproximal areas, the assistant is standing by with the aspirator so that she can cleanly remove the tags and remove the bits of tissue and debris from the aspirator tip, which keeps the tip area clean and free from the accumulation of calculus, from the accumulation of the tags and bits of tissue, so that we can see more clearly in the area to carry out our debridement procedures. There are times when it is also helpful for the assistant to retract the tissues or retract the cheek or the corner of the mouth with her finger so that we have access into areas maybe related to the surgical site. This provides me better visibility into the surgical site. There are also times when she may take a mirror and retract the patient's tongue. In working in the lingual areas, if you can take the mirror and hold underneath the patient's tongue, sometimes a very active, rigid tongue may tend to move forward into the surgical site, and with the assistant utilizing the mouth mirror, the placement of the mirror can keep the tongue from coming forward into the surgical site so that we have, again, the best visibility and access for debridement of the area. Irrigation with saline solution is also helpful during the course of the procedure, again with the need that we have for clearly visualizing the roots of the teeth, for clearly visualizing the bony contour of the area. The irrigation with saline cleans the root surfaces, cleans the crestal bony areas so that we can see more clearly the root surface to make sure that it's smoothly planed and is free from calculus, as well as giving us a view of the crestal bony contours so that we can observe any bizarre patterns of bone or see if there is any necessity for reshaping of the bony edges that may be quite prominent or not placed so that the desired contour is gained. There upon occasion may be little tags of tissue, pieces of tissue that we're not able to clearly visualize, and many times it's helpful for the assistant to attempt to hold the tag of tissue so that we may see it more clearly, so that we may determine the attachment of the tag of tissue, and in doing so we can then, finding where the attachment is, we can displace it with the curette. There are also times when these small pieces of tissue can be picked up with a mosquito clamp, and again we can then more clearly see the attachment of the tissue, and in doing so we can then get to the base of the attachment and curette it so that we're able to remove it. Let me have you retract with the number 7 retractor the flap so that we can see into this one interproximal. We have one interproximal that I would like to view closely, and in order to see that, it would be of help for me for the assistant to retract the periodontal flap. You noted then that she has placed the retractor underneath the flap and is resting the metal retractor on the alveolar bone. This is desirable as opposed to placement of the periodontal reflecting instrument, the surgical reflecting instrument, on the tissue flap, because in that case the tissue with the movement of the metal retractor back and forth across the tissue, the area is more unstable, there is more trauma to the tissue flap itself, and with placement of the retractor directly on the alveolar bone, a more stable reflection of the flap is possible, and at the same time then I have a more clear view into the one defect that we're concerned with in this case. Move the retractor here for me now, please. For a final checking then of the root surfaces from the lingual aspect. Periodontal probe, please. During the course of the procedure, the instruments in the mirror will tend to pick up some of the bleeding, and again helpful for the assistant to take the instrument and clean it off with a saline sponge. Irrigate directly in the interproximal areas, please. Having completed then our scaling and debridement in the interproximal areas, and having made certain that the root surfaces are clean and free from calculus and smooth, we are to the point then where we can begin to check our flap for the placement of sutures. Many times you will note that there are some tags of tissue along the underside of the flap or around the edges of the flap. As the assistant stands by then with the scissors, we are able to move with the scissors into the flap area to remove the tags of tissue on the flap, to possibly reshape the flap so that the contour is more appropriate for replacing and suturing. Retract that with your aspirator, Rennie, just. As regards the tags that we find underneath the flap, there are times when, again, these are hard. It's hard to distinguish where these are attached. And with the use of the aspirator, the assistant can pick up these tags with the aspirator. It again permits me to visualize the attachment of the tag and excise it or remove it with the sutures, scissors. There's one more right here, a bit of a tag here that, again, holding with the aspirator, being able to see the attachment, we can very nicely excise that so that the underside of the flap is smooth and will adapt nicely into the surgerized area then for suturing. The use of a gauze sponge to press against the flap to note the adaptation of the flap, to again clean in the mucobuccal fold area, permits us to see the edges of the flap, the contour of the flap, just prior to suturing. The assistant also is most helpful in, as we work in the area, the ability she has to view the surgery site from a different side gives her the opportunity to point out to me any area where there may be tags of tissue. She can be of assistance in helping us locate these tags and see them from her side of the chair, and this permits us to review the area more thoroughly, removing the tags or any loose bits of tissue that may be cleaning in the interproximal areas. Now, if I may have a suture. You may close and rest, Mr. A.G. a moment. As we are preparing the suture, the assistant has determined the access that we'll be making with the suture and is placing the suture in a manner in the hemostat so that we may go directly into suturing of the surgical flap. Will you retract the lip for me in that area? The interproximal area between these teeth, as you may have noted, the teeth are malposed and are close together, some difficulty in passing the suture through the interproximal area. You note, though, that the assistant has guided the suture so that we are able to get into the interproximal area, and so that the suture then does not drag across the chin of the patient. That area being quite tight, we'll have to pass the suture through the contact point before we can gain access to the lingual. We are nearing completion of the placement of the sutures at this point. As you note, the assistant continues to retract the lip as necessary so that we have a clear view of the tightness of our suture. I would like to emphasize one point at this time in regard to suture cutting. There's a tendency, I think, to want to cut our own suture. If the assistant is able to cut the suture, we're able then to clearly reflect the lips or the cheeks as necessary. We're able to make certain that these tissues being reflected are not traumatized by a pinch or a cut from the scissors, and the flap then is able to be viewed clearly. The suture then can be cut at the appropriate site. Now, having completed the placement of the sutures, we'll move to placement of the acromycin ointment. This is standing by on the countertop, and we will use a plastic instrument to place the acromycin ointment. Mirror, please. The acromycin ointment, as you see, can be placed in the labial portion of the surgical site as well as the lingual portion, trying to manipulate the instrument so that the interproximal areas, the entire surgical site then is covered with the ointment. Now we can move to preparation of the periodontal dressing and placement of the periodontal dressing. This material has been pre-mixed and has been placed out so that at the time of surgery, manipulation by rolling in the hands, rolling between the fingers, is adequate for softening of the dressing and placement at the surgical site. Occasionally, the texture of the dressing may be more firm than at other times based on the amount of powder that has been incorporated into the dressing. It may require a fair degree of manipulation or rolling in the hands. At other times, if the dressing is more soft, less manipulation is required. The assistant has visualized the approximate amount of dressing that we will need and the diameter of the roll we will need, and we will simply then take a portion of that size roll of dressing, carrying it to the mouth, adapting it first on the lingual. Retract the lip, please. Adapting the dressing then into the interproximal area. Our assistant is standing by with a gauze to take the excess dressing. We attempt in manipulation of the plastic instrument to carry the dressing into the interproximal areas, utilizing the interproximal areas for retention for our dressing. There will be bits and pieces of dressing that the assistant will be able to clean off of the plastic instrument. We need to guard against having an overabundance of dressing, because the potential for the dressing to flow up onto the occlusal surfaces or onto the incisal edges, and therefore the risk of fracture of the dressing is great. So we, in manipulating and placing the dressing, place it so that it stays into the interproximal areas. Now we need a piece of dressing for the labial aspect. Can you give me some aspiration in this labial area? We again visualizing the surgical site while the assistant again retracts the lip. We're able to see reasonably well and estimate the amount of dressing that we need to place into the area. As our assistant retracts the lip or cheek and stands by with the plastic instrument, we can again manipulate the dressing so that it is carried to place, utilizing again the embrasure spaces for retention, and any excess of dressing being taken by the gauze sponge that the assistant has. Periodic use of the aspirator tip again helps us to view the interproximal areas so that we can see that the dressing is being firmly placed into the interproximal areas. Smoothing the dressing so that it does not tend to irritate the patient's cheek, and then cleaning the area finally with a saline sponge so that we have a chance for a final view of the dressing placement. Close together, please, all the way on your back teeth. Noting then that the dressing is clear of the patient's occlusion, and it seems to be well adapted into place, covering the surgical site and utilizing the areas of retention in the interproximal areas and around the teeth. Our surgical procedure at this point is complete. The assistant can carry out the final cleaning procedures for the patient's face. We will be following the patient during the healing process over the next several weeks. A final application then of Vaseline or petroleum jelly to the patient's lips, helping to lubricate the lips that we have retracted and done some pulling and stretching of during the course of the procedure.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.